Welcome everyone, and I would like to greet you actually at the first HPBA webinar on evidence-based medicine. As you might know, EHPBA has webinars almost each month on difficult or different topics in HPB surgery and our HPB fields. And what we're trying to present you today is the first thing. And as you might know, HPB or EBM evidence-based medicine is a very broad field. And of course, one webinar would be not enough for it, but we just tried to give some basics today for you. And my name is Paulas Ignatavicius. I'm HPB and liver transplant surgeon from Kaunas in Lithuania. And one of the things I'm teaching in our university is evidence-based medicine. And together with me today, I have two friends of mine with whom we had already had several evidence-based medicine sessions live during our conferences or postgraduate courses. So we have already worked in a group, and we have Daniel Hartmann, who's now working in Tübingen, Germany. He studied several years in Germany, then United States of America, and worked for some years with Helmut Fries in Munich, and since some time moved to Tübingen and has a vast experience in HPV surgery. And also we have Giovanni Marcegani, who is currently working in Padua in Italy and who also spent a lot of time in Verona and has also a vast experience, especially in pancreatic surgery, pancreatic cystic tumors. And I think that's a very good combination that our both panelists, Daniel and Giovanni, they have not only experience in clinical surgery, in skills or managing patients, but also a lot of experience in research. And that's, I think it's very important for evidence-based medicine to mix these things and to give the best possible care for our patients. So just very shortly, some housekeeping rules for the webinar. I think most of you know how to use Zoom, and actually you are not allowed to change a lot of things. You cannot unmute you, or you cannot share your videos or anything else. And the webinar takes 1 hour, and we start with a presentation by Daniel, then follow my presentation on clinical study design, and it will be finished by Giovanni on artificial intelligence in evidence-based medicine, and then we will have several minutes for questions. You can use the chat function just in case you have any problems, and Carrie will try to help you or solve it. And for all the questions, please use the Q&A section. That will be much easier. And then at the end, we can go through that. And just to remind, the session is recorded and it will be made available later on to watch on demand. And also we encourage all of you to share this webinar or what you think about it on social media with the hashtag EBMHPB. So I would like to invite Daniel Hartmann to give a first presentation, fundamental things on evidence-based medicine and levels of evidence-based medicine. So Daniel, please.
Well, thank you very much, Povilas. That's really a big honor for me to be part of this webinar. Really glad to be part of the group. And as Povilas said, together with Giovanni and some other friends who I've seen are also in the audience, like Rita or Getrius, we have had some evidence-based medicine courses, especially at some Eastern European countries, which have been well received. And we are happy if we can reach a big audience here using E-AHPBA webinar series. And let me start with the slides. So I'm a senior surgeon at University Clinic in Tübingen, Germany. And I've previously been working in Munich. Of course, I've also made a lot of experience in research, especially when it comes to evidence-based medicine. And that's also learning by doing, but also partnering up with our friends also from abroad. People like our colleagues like Giovanni and Povilas are also friends and colleagues that I've worked over the years. And we have also worked on projects, research projects, and also through these means we have been able to learn from each other and also apply evidence-based medicine. But let me first start with a short introduction. And especially when you're doing research, but also when you're treating patients, it's something that you take a lot of responsibility in, because medicine is dangerous. There's a nice quote by Cyril Chandler, 25 years ago mostly, who says, now medicine is complex, effective, potentially dangerous. It used to be simple, ineffective, safe, but now it's becoming more and more dangerous. Why? Because we have, of course, a lot of tools, medicine, medication, but also in our instance, for example, robot surgery, where we are treating patients with new methods, which are sometimes not fully known how the evidence is, but we apply them. And for these reasons, it's very important for us to really appraise the evidence in the right way and then use it on our patients wisely, looking also at the literature. And why medicine is dangerous can also be seen through these figures. Up to 98,000 deaths annually from medical errors in the US, equivalent to actually 2 large airplanes crashing daily. That's the risk of medicine, of healthcare. And therefore, we have to use the tools that we use in daily routine wisely and have to know the literature. And also surgery, and most of the participants here in the webinar are probably surgeons, do every day in their daily routine surgery. And we know that around 4.2 million people die worldwide within 30 days of surgery. Most of these patients, or a lot of these patients, for elective cases. And for these reasons, we have to be aware it's one of the top 10 global causes of death. And therefore, the medicine and the surgery we do needs to be wisely chosen, and we need to know the evidence behind it. So why do we need evidence-based medicine? As I said, variations in clinical care. There are many innovations out there in healthcare, and we also have to be able to rapidly adopt also unproven innovations. But for these reasons, we need to know the tools how to judge these new innovations. We also are using treatments with unknown efficacy, and we need to know as soon as possible how efficient or how good a treatment is. And we need to know the sources where we can find this information. In addition, there's rising healthcare costs, there's increasing complexity of care, and of course, there's also patients' demand for reliable information. Patient ask you, patient also look on the internet. A lot of patients are very differentiated and might ask you also about some facts. And for these reasons, we need to know the sources and need to be able to use evidence-based medicine in our daily practice. Where does the term evidence-based medicine come from? Well, one of the founders of EBM is David Sackett, who, quote, says, EBM is the integration of best research evidence with clinical expertise and patient values. And this really brings it to the point. And he has had a lot of publications about it. It's also that we have conscientious, explicitly, and judicious use it, the best current evidence in making the best decision for our patients and the care, as it says here, for individual patients. So all of us, we have our individual clinical expertise. We need to find the best external evidence through the sources that we have and the patient values and expectations. Together, this forms evidence-based medicine. I know this introduction is very theoretical. When Povilas and also Giovanni will give their talks later on, there will be a little bit more hands-on, but that's let's say the most important point I want to make when we come to the introduction of evidence-based medicine, why it is important. And of course, background is patient safety and quality assurance, just as I've just said in the beginning, how many medical errors are out there every day. So we need to make sure that we know the gear wheel and that we know the single gears. So as this gear says, key metrics and reporting, we analyze our metrics, we model, and then we perform decisive actions. So that's one of the gear wheels. Another one is, or another gear is the research, also the translational research from bench to bedside, bedside to bench, in order to improve outcomes. research and development. And here EBM comes into place, where we put the theory, the theoretical knowledge, the findings from research into practice. The three pillars: discovery, so research and development activities, then integration into our daily clinical practice, and also maybe yourself design and perform medical studies in order to improve patient care and outcomes. And another pillar in academic medicine, and another gear in this gear wheel, is education. And that's also, all of you that are participating here in this webinar are multiplicators. You might also teach your own students, fellows in EBM, in evidence-based medicine, and bring the evidence to the patient and also to your students. And therefore, not only discovery, so the studies, integration, application, but also reproduction is very important. And for these means, I put another fourth pillar of academic medicine here. I also want to make the point, evidence-based medicine, of course, we use it every day, but we might not be completely aware of it. And there are several studies out there. I picked 3 representative studies, maybe also pointing out the importance of EBM and the integration into our clinical practice. So there's one study that looked at the knowledge and use of EBM, of evidence-based medicine in daily practice by health professionals, cross-sectional survey. And here the physicians, you see, some don't know about it, some have just heard about it, a lot of them don't practice it. There's only around 36% who use it occasionally or regularly, and that's not enough, especially since we make very important decisions in our daily life. We are also teachers, and therefore it's very important that evidence-based medicine is taught, that we are aware of it, and that we make use of it. Another interesting study or survey was the self-rated skills in the use of EBM. And as you can see, a lot of knowledge and a lot of things that people use as sources are textbooks. And in a lot of cases, as you can see here, the Cochrane Library or other databases is not as frequently used as textbooks. But we all need to know that studies that make it to textbooks might take 15 years until you can find them in textbooks. And therefore, textbooks might be outdated. So we need to use the sources that we have. And for that reason, it's so important to make sure you are also being taught in evidence, and you yourself teach evidence to your students. Another interesting survey, which makes it clear, this is a survey on participants of EBM courses, just as you are now, if you follow the series. So in green, you will see participants in EBM course, and in blue, the answers of doctors or medical students that have not participated in EBM course. And you see the ones that haven't participated in EBM courses have higher use of printed books. It's significant difference. And the ones that have participated in courses know the other sources. And that's something that also Giovanni will give in his talk, the really important finding the right source for the evidence, finding the right source for your clinical decisions. And here you can see the participants, the Hungarian participants here, used online journals or professional guidelines in a higher number when they have participated in EBM courses. And therefore, this is a subject that is probably not often taught also during your studies and later on, but that is very, very important. Of course, there's a lot of sources out there. We know the number of journals and publications is increasing. It's even more increasing. There's an epidemic of evidence. We know it all. When we go into the literature, when we type something in PubMed, there's 5,000 articles per day, maybe even more, even 75 trials per day being published. So finding the right source is really not easy. Staying up to date is even more difficult. And we really have to filter and make sure we find the evidence on a normal way, that we don't are over-occupied with it. And therefore, the talks after mine are even more putting an emphasis on this. Last but not least, I want to really make sure we are all at the same level when we start now this course. So you know the validity. Most of you know that the highest validity is with systematic reviews and meta-analysis. But however, it gets blurred. Sometimes it's not even very clear. But to make sure you know that systematic review and meta-analysis really put into focus the results of case series, reports, control studies, cohort studies, randomized control trials, bring it at an easier way of understanding, summarizing the results of these studies. So a selection and filtration of studies happens here, and that's, of course, a very valid source. What do we want to achieve now in the end? At the end of this webinar series, we want to do the right thing right from the first time and at the right cost. And we need to ask the right questions. And of course, every one of us has a different background. We might ask different questions in our daily life and our daily clinical practice. So just to have some examples, what is suitable for treating a condition, what dressing should we use, one act in the end of an occurrence, symptoms, how much fluid should I be given? There are many questions that we ask during daily life, but also, is our patient similar to one in the trial that I've just read? Is the described treatment advisable? Is benefit bigger than harm? Is there a better option for my patients? Is it in line with the values of the patients or the interests of the patients? Is the solution applicable in your healthcare system? These are all questions that we are asking when we then acquire the evidence, appraise the evidence, apply it, and assess our performance. So these steps of EBM are important. Think about the 5A questions when you apply evidence-based medicine in your daily practice. Acknowledge, ask, acquire evidence, appraise the evidence, apply it to the patient, and assess practice. So with this slide, I go over to the talks of Povilas and Giovanni after this short introduction. So I hope you are more interested in learning in this EBM series. And of course, I'm also open to any questions that you might have at the end of this webinar. Thank you very much.
Thank you, Giovanni. Thank you, Daniel, very much for your presentation. And I think it was a great introduction to the evidence-based medicine. And please, participants, just ask the questions. I think we will go through them at the end of the webinar. And now I will move to my presentation, after which follow the presentation by Giovanni. So I just share my screen. So just a short presentation, again, 10 to 15 minutes on clinical study design, and some slides might be the same ones which you saw on the presentation by Daniel. As both of us said, we have already worked a lot together in this field of evidence-based medicine. So some slides are the same. Maybe we have different interpretation or want to acknowledge different things. And also today's webinar, one of the reasons or goals is really to show and present the basics. For some of you, things what I will be talking about or showing might look just too simple, but it's just the idea to get you know a little bit better about evidence-based medicine and really the basic things. This slide you already saw, it was shown by Daniel, and also one of the problem is that the number of journals of publications is increasing, and the idea of evidence-based medicine also is or should be that we just learn a little bit better to know what is a good evidence, what is the bad evidence. Does it always matters only impact factor of journal? Maybe impact factor is boosted and there are other reasons. Maybe the journal is a low impact factor journal, but it's a good journal and it's a good publication. So all these principles of evidence-based medicine are very much needed when we have such high number of publications and journals. And some of you also might know or heard the word paper mills. These are some specific groups of journals. These are very big groups and they are producing a lot of special issues. And I suppose a lot of you get every day some askings from these groups, from journals belonging to these groups to publish something or to be a guest editor. Of course, also in these groups of journals, there are good journals, but these some of them, MDPI, Frontiers, Hindawi, are really big, and there are a lot of discussion in the research and medical fields. Is it a good thing, these special issues or not? And also, some of these groups and journals are really a good business model, I would say. They are, because we as authors, we must pay when we want to publish an article, and these groups actually earn a lot. But what's happening in the last year, more and more journals belonging to some specific journal groups are retracted from indexing websites, indexing databases. So you should also be aware of some of these things. And again, evidence-based medicine gets more and more important when we are talking about these things. Another thing about what will be Giovanni talking later on is artificial intelligence, and this is just example. It circulated on social media maybe a year ago. It's not a medical journal. It was published. It's a journal with impact factor, and of course it underwent a review by editor and review by a group of people. And if you ever have used ChatGPT, you know that's what's in yellow. Certainly, here's a possible introduction for a topic. This is mostly what ChatGPT starts saying to you when you ask a question. So just to illustrate that artificial intelligence also is not only a good thing, but it's also a problematic thing. But I think Giovanni will be talking about it a little bit later. So another thing when we're talking about this high number of journals and publications, very good illustrates this example. It's already 11 years old. It was published a study looking, because when you're reading some papers, you might find, yeah, wine helps against cancer or something causes cancer. And authors of this study looked into 50 different products, what we are eating and drinking, and they found a pretty similar number of studies showing that these products are causing something, and very similar number of studies showing that these products are protecting against some diseases or cancer. So again, how to know now? What should I believe? So which publication is a good one and which is not? So again, this is a place for evidence-based medicine. And this slide again, Daniel has already showed you. And what about, I'm talking clinical study design. It's more about acquiring the best possible evidence. And really, this is a nice figure. I suppose for a lot of you, it's very well known, all these different types of studies. But for some of you, it might be a new thing, or it just helps when you will be teaching your students, your residents, your PhD students. So when we're reading a study or when we want to perform a study, one of the simples or the first questions might be, did the investigator assign any exposure? It means, did investigator perform a study comparing two new medications? For example, a group of patients, group one got a new medicament and the group two got an old pill, and the investigator compared with groups. If not, we are talking about observational study. So this is the first question, and we know, is it observational or not a study? The second question could be comparison of groups. Did the investigator compare groups in a study which we are reading? If not, it's a descriptive study. They described, for example, a case report, which might be a descriptive study. And the third question, actually the last one, if you want to know in general what kind of study is it, in what time direction the study was performed. So we might go for a cohort study. It means it was started some years ago, maybe 10 years ago, or much more years ago, and we followed a group of patients or subjects for many years. So we moved from time into the future. It took many years. We're talking mostly about cohort study. Another group of studies, these are mostly when we are looking in databases, in registries, in medical documents. These are the case control studies. Everything has already happened. For example, the patient was operated and has a complication, and we are comparing a group of patients with complication, a specific complication which interests us, with a group of patients who doesn't have that complication. And we are looking into a database, into medical documents, and we are trying to find some risk factors. And if we are doing everything at the same time, it's processional study. It means we are not following these patients. We are not looking back in time. We're just doing at a time moment. For example, if we would do a study now based on these webinars with all of you, just send you some survey, or compare some of you to another, but we are not following you and not getting your data from behind. So we might be talking about cross-sectional study. And another big group, these are then the investigator or you have assigned a new pill or a new surgical method and compared to the old one or to the gold standard. Mostly we are talking about experimental studies, and in this case, mostly about randomized control trials. These are really very high quality trials, but they show you later what are the advantages and disadvantages of these studies. So again, this slide was already also shown by Daniel. But what I want to mention, that it's really not always very clear and easy to say which study is cohort study, which study is case control study. And when you're reading, it might look, yeah, it looks like, or the author saying this is a cohort study, but I think it's case control study. Not always it's matter a lot, but especially if you're teaching your juniors or you performing a study, it should be a good thing to follow guidelines. And systematic reviews and meta-analysis are the thing where we compare the data and analyze it. And what's also happening in the last 5 or something like that years, more and more systematic reviews are published. And if you saw in this slide, systematic reviews are on the top of the pyramid. It would mean that these are really high quality trials or high quality studies, especially if a meta-analysis was performed. And most of us suppose that the systematic review was made from a group of randomized control trials. But as I said before, more and more systematic reviews are published, which are based on some case control studies or cohort studies. So it means a systematic review was made on not that good quality studies, and it doesn't make the systematic review a better quality. So you should, again, be aware when you're reading a systematic review or a meta-analysis on what kind of study it was based. Was it randomized control trials, or the authors are stating that we didn't found any and we made it on cohort studies? So this slide also just very shortly illustrates that we have a population of our study sample. This is a sample on which we are making a study, or the authors of the study we are reading made a study. And of course, the idea is, or to avoid all the systematic errors, you see the bias and random errors, that it should, in the best possible way, to represent the population of interest, because it would be not possible, for example, to collect all the patients with acute appendicitis in Lithuania for 10 or 20 years. It might be, I think, really too difficult. So we go for a study sample. We say we do study in this particular city or in this particular hospital, and we just collect data, but we hope that it will represent the population of interest. So now I will just go to some examples. As I said before, they are really simple ones, but just to make aware you that there are really different types of studies. So one of the first ones, or really the simple ones, are the case reports. And in this case, the authors are talking about gallbladder herniation. Is important for our personal clinical practice? I would say no. If we have a herniation, an incarcerated hernia, we will be operating it. But in some cases, case reports has their place, or if you are starting your career as a scientist, it might be a good thing just to thinking about writing a case report. Or if you find several cases, you're working at a big hospital, you might find several cases and publish data on that, and it will be called case series. And in some cases, it's also important, and my last slides later on will show where's the place of it in the whole pyramid of data or clinical practice. So we're talking about clinical cases and case series. What's the advantages and disadvantages when we are doing it? Advantages, of course, it's fast, cheap, because you just mostly need your time to read the medical documents or go through a database. And it's good for very rare diseases. It might be not possible to perform a cohort or case control study. Disadvantages, these studies are retrospective, we don't have any control, and the applicability is in most cases very low. Another thing, unfortunately, it's not on HPB surgery, it's a study about smoking and the dementia in male British doctors. And as you can see, the number of included subjects is really high, or more than 30,000. And it was started really many years ago. And these are really high quality cohort studies. The study personnel or authors, investigators collected a large group of subjects, and we tried or started to follow up them already 70 years ago, more than 70 years ago. And you can get a lot of data from such kind of studies, but it's really difficult to perform. And these are called mostly cohort studies. We have a study sample, and then, for example, in that case, we have some study subjects who are smoking and study subjects who are not smoking, and we are following them in time for 5 years, for 10 years, for 15 years, or 20 years. And we can look what kind of disease they have developed, what kind of problems they have. Advantages, mostly prospective studies. We are very good to know confounding factors and causality, but also we have some disadvantages, high number of subjects. They take a lot of time to perform, and also it's related to high cost of these studies. Another group of studies, it's a little bit maybe a long abstract, but we just can go to results, and we see that 173 patients received preoperative chemotherapy and underwent surgical exploration. We're talking about metastatic pancreatic cancer, and in this case, all these patients who underwent a surgery, part of them underwent a resection of metastasis, and part of them underwent only exploration. And the authors compared two groups. So we have, for example, we can say, let's say that our controls are these patients who underwent exploration, and cases are these the new ones who underwent resection. So we are comparing two groups, and in this case, we are talking about case control study. We have a study sample. We already know what's happened to these patients, and we're looking in the database, let's say back in time, and looking for some risk factors or confounding factors or other factors where might cause a better survival or higher incidence of complications. Advantages, again, fast and cheap. It's a relative thing. Of course, you have to have a good database, and it might take some time. It's more suitable for a little bit rarer diseases when you need a little bit longer time to collect data. You have control group, but of course, it's retrospective. A lot of unknown confounding factors, and that's why the risk of bias is high. This one is maybe a little bit difficult to present, but it's a study. I would say it's a cross-sectional study. It's when 10 cases of colorectal liver metastasis patients with images were sent for expert liver surgeons, and we asked them of their opinion, what they think about these patients, what we would do in that case, but we didn't look or didn't follow these doctors or experts to the future, and we didn't look back in time. And we might call these cross-sectional studies or survey studies, and we have, in this case, not a study sample of patients, but a study sample of experts who we asked about how we would manage patients with colorectal liver metastasis. And we're looking at one point in time. We are not looking backwards, and we are not looking going forwards. Advantages, again, maybe fast and cheap, prevalence estimation, ethically more safe, but disadvantages, groups are very heterogeneous. We have different factors, and it's difficult to find a connection. And the last one, big group of studies about antibiotics or prophylaxis in pancreatidodenectomy. Several months ago, published a very good study, and in this case, we are talking about intervention group and control group, and it's a very good randomized clinical trial. And in these studies, we have a population, patients, for example, who underwent or pancreatic cancer study sample, selected patients with pancreatidodenectomy, and control group, what's they're getting in a normal way, and study group, that piperacillin tazobactam, and we were looking for complications. So these are looking forward in time, advantages, prospective groups, we have equal groups, high level of evidence, but of course, most of them might take long time and are expensive. Sometimes randomized control trials have limited applications, and of course, they are not always possible. So again, the same slide, pre-questions. Did investigator assign any exposure? Did we compare different groups, or what was the direction of time? Did we look backwards in time? Did we follow this patient? Or we just done a momental study, we call it cross-sectional study, at one moment of time, and we did not follow this patient backwards or forwards. I think now I will just skip some slides because of time reasons. I will just leave them for next time. But my last slide would be this one. It just shows very nicely that we have different types of studies. And of course, we saw this pyramid of levels of evidence, and we know some studies a low level of evidence, some has a high level of evidence. But when we are taking some decisions, when we are treating our patients, sometimes really we have to look into case series. Sometimes we might find a randomized control trial. Sometimes we need data from surveys, or even we have to ask our chief or professor at our department who has a lot of experience. And from all these studies and databases and data, only then we made a decision, not only based on one single study. So thank you very much for your time. And I'll just stop sharing my screen. And now I would like to invite Giovanni to talk about positive and negative things about artificial intelligence and evidence-based medicine. So Giovanni, please.
So it was really great so far, but we need to tackle one last aspect, which is AI and EBM, and I will try to go to some key points as take home, because whenever I hear about AI and EBM, I always feel like I really don't get what the point is. So I really want to, first of all, disclose that yes, you can do many things right now with AI tools, like the one that you know, and this implies also this presentation. So we'll go back to this concept at the very end of my talk to see whether you agree that even to prepare something like this webinar can already use AI tools. But I promise that no robot or AI was exploited, nor suffered for something wrong about this presentation. So as it's already been said by Daniel and Povilas, I mean, we are really not talking about something new. I mean, AI is definitely not the new kid on the blocks because it's here since just a couple of years. So of course, there is no time to go through all this story, but just to realize that these tools already are part of our life, not only scientific part. Unfortunately, no laws, no recommendations are available because even going through this European Union Artificial Intelligence Act is somehow hazy, and it's almost impossible to understand what the real implication for digital medicine are. I even asked to an expert to help me to go through that because it's really brand new. It's from June 2024, not clear. So probably we even face some issue from the politics right now, rather than just focusing on AI and EBM. But again, I'm not going to throw this concept. We really need to ask ourselves what AI mean. And you know that there is a huge difference between AI, machine learning, deep learning, and I'm not going to go through this concept because we have no time. But just think that all these tools are now integrated and are already part of our everyday life in an app like this that you all know. So focusing on the topic, first of all, the first key concept to understand how AI integrates with evidence-based medicine is understanding the process, getting to know what it means to go from problem selection and data collection to actual data provided by AI. You see how there needs to be a very long and important process, and I'm going to go through all these aspects pertaining to model training, prediction, and informative validation. So large data sets are needed and high quality data sets are needed. If we don't have this, the outcome in the end, which is our critical decision, is at least biased. So be careful when it comes to this concept. You've already seen this, which are the pillars of evidence medicine. Where is the role for AI in all these aspects of evidence-based medicine? So we have to go through all of them quickly, but we have to, starting from clinical expertise. So clinical expertise is basically threefold. First of all, we have an area which is population health management. Do we have a role for AI in that? Of course we do. We need to add the historical data with current data to build strong predictive model. And this is, of course, in the end, beneficial in terms of outcomes. We have many examples of that. For example, we can already, predict readmission rate by using AI. Imagine the implication for healthcare system when it comes to this predictive model. So yes, it is already what's happening in the current world. But then we also have the issue of diagnostic accuracy, and Povilas was going through that. It's absolutely mandatory to get to know that even now we have a way to integrate what comes from histology, imaging, and clinical data to eventually decode data to have reliable predictive models. It's really no game between man and machine when it comes to prediction. These are just some of the examples of all the studies that are now published when it comes to the approach by evidence-based medicine with AI tools compared to man. I mean, we don't need many randomized control data even to understand that there is an outperformance of the machine, so to say, against the man. So it's really not a competition, guys, between us and AI. What about clinical decision support? This is extremely meaningful. Imagine that we can integrate, for example, when it comes to gallstone disease, preoperative, intraoperative, and postoperative AI tools to, in the end, deliver better care for our patient. This being one very, I would say, easy example. I'm sorry for the voice in the background.
Bluish purple color and the liver in green.
Yeah, you see this? This is an also surgery paper showing you that we can already use this tool to perform a safer cholecystectomy. Finally, care delivery. We know that we can rely now on AI-powered application, chatbots, and interfaces by providing assistance on virtual health, mental health support, and finally, patient education. So it is clear that we already have a role for AI in clinical expertise. What about patient values that are, of course, a critical element of evidence-based medicine? We always face this sort of imbalance between clinician decision and patient's preference. Can AI play a role in that? Yes, the answer is yes, because as all these factors come together in sort of a conflict, we can resolve part of these conflicts by increasing patients' education and autonomy, to have a safe time for patients-clinician interaction, and to alleviate the burden on us as clinicians by a true shared decision-making thanks to AI tool. This is truly revolutionary and, of course, also conflict resolving. Finally, we have to deal with best research evidence, and again, to the question, how can AI enhance the level of evidence that we are looking for? We can deal with study design, data analysis, and even manuscript writing with tools that are already available. When it comes to study design, we know that AI can help us in knowledge gap identification, research development, and even article outlining. We don't have to fight against that because these are just great tools. When it comes to data analysis, we know that AI can help the statistical analysis. For example, very practically, even in create tables and figures, there is nothing wrong, to even think about that. And I just want to remind you, already saw the pyramid of evidence-based medicine, that we do have already some tools that are extremely helpful, for example, in building systematic review. This is a systematic review on how we can use AI for systematic review. And we know that we have already numerous AI systems to facilitate the screening of titles and abstract. And again, I said that this is extremely helpful for all of us if you remind when you did for the first time such a systematic search. What about randomized controlled trial? What we aim at when we want to increase our level of knowledge in surgery. AI is being now currently used to accelerate some process, like the trial design, patient recruitment, but even patient retention and data management. we know that all these can come together, making our life easier, so to say. And that's great. But even in cohort studies, I'm not going to go through all the steps that can be accelerated by AI. We can have a significant role played by these AI tools. When it comes to the next step, we know that we can ask AI, for example, for title generation, right? Because we can have the suggestion of potential titles by the AI. I talked to some friends that are artists, like musicians, and they were surprised that while we thought at the beginning that AI was not really able to create something, so we thought it was more for boring stuff. The great thing is AI can help also by generating things as these creation models like title generation, writing supports, and stuff like that. But also we can use AI for plagiarism detection. And as an editor of a journal, I can tell you that this is a great tool to identify whenever plagiarism is there. So once again, those are fantastic AI applications that are currently used in the editorial world. Which are the results? Povisa showed you this slide, and we all were into this scandal of having just a copy and paste by something written with the ChatGPT. Is this a problem of AI, or is this a problem of the peer review process? I would like to ask this to our panel, when it will be time for discussion. But I was one of the ones that posted on social media something like that, because it is really something that needs to be underlined and analyzed when it comes to this plagiarism. But you know that the use of AI for medical writing has also some disadvantage. So I don't want to sound you too enthusiastic about that. We know that there is a lack of critical judgment and also limited human input. So to say that these tools, they do not really create anything, indeed they analyze countless interactions to come out with something that seems to be new, but indeed is not really new, is never really new. There are also problems related to cost, misinterpretation, potential bias. So we know that there are some critical disadvantages in the use of AI for medical writing, and you as researchers should be very well aware of that. At the same time, I want to leave you with this concept. We really can see AI in this research field as a co-pilot. So the co-pilot is someone that you would really always want to have. It's like the best colleague you can imagine of. But this does not imply a replacement of your figure. Anyhow, I would say. So the use of AI for medical writing has some also ethical issue. So I want to underline that there are issues when it comes to privacy, data security, lack of transparency, ethical values. All these are very, very important factors. You know, the debate about social media, for example, owners of social media now becoming politicians, taking the power. And so, of course, when it comes to ethical issue, it's always important as a scientific community to underline that we should not take all this for granted. We need to be critical, always, always critical in life, not only when it comes to AI. And what about the academical journals, like the one, for example, I am part of? Well, you have to be aware that right now, what they ask to authors is being transparent in disclosing in the materials and methods or similar sections whether the paper has used an AI tool, why, and for which outcome. So it's basically a statement, right? Which is similar to the recommendation to always define what was the actual role of an author in the process of drafting a manuscript. So it's just like AI is one of the authors of the manuscript. And I think that this is extremely acceptable, I would say, because this is not fighting against AI, it's accepting AI in the world of editorial. So again, yes, AI can be integrated in all the aspects of evidence-based medicine. And going back for the last time to the pyramid of evidence-based medicine could probably serve, if we see the pyramid as the tip of an iceberg, as what is now under the water of that same iceberg of evidence-based medicine. So far to be explored, but so deep and so important as the learning that is coming with us. So to conclude, AI is a great tool to enhance evidence-based medicine, but I would add, of course, it needs an AI-related clinical competencies for all of us, for all healthcare professionals. There are, I would say, a wide spectrum of aspects that needs to be covered, and I hope that in these 15 minutes I was able to convey you this message, but I want to leave you with this. New generation will look at us the same way we see math teachers protesting against the use of a calculator some 60 years ago. So we should not really look clumsy when it comes to say, let's avoid AI because it's somehow dangerous or it's not human. Well, if you find that protest as ridiculous, think about what our mentee will think of us in some 50 years if we now think about AI as something dangerous and something evil, so to say. So I look forward to the debate to all of you, and I thank you for joining us tonight for this wonderful E-AHPBA meeting. Thank you so much.
Thank you, Giovanni, for a great presentation on artificial intelligence, and it's an important thing in the last years, I would say, and getting more and more popular. So now we have still several minutes left for a short discussion and for questions. I just will try to see. We have one question, and it is, what is the difference between retrospective cohort study and case control study, or they are the same thing? I might try to answer it. It's really, I showed in my presentation just the main types of study, and the line is really blurred, and it's sometimes really difficult to say, is it cohort study or is it case control study? And the authors sometimes are using these words very freely, but in general, when we're talking about case control studies, the outcome is already there. We have a complication, and we're trying to look for an exposure which might cause that outcome. When we're talking in general about cohort studies, retrospective cohort studies, we know the exposure. We know, for example, as I showed in that cohort study, some group of subjects smoked and some group of subjects didn't smoke, and we are looking for some outcomes. But the line is really blurred, and it's sometimes difficult to say that. So, Daniel, Giovanni, do you have any remarks or questions what you would like to give in the last few minutes?
You mean with regard to that question or in general?
No, in general, actually, I might ask I wrote down one question for both of you. I think we have left 3 or 4 minutes, just because we're talking about evidence-based medicine, how easy is to implement it in daily practice at your institution. For example, you read a study, and of course, when you're a chief of department, maybe it's easier. But when you are a doctor, a junior one, what was your experience before many years ago? For example, you read a study, is it easy to implement the change in daily practice?
It depends. It's hard to answer generally, but let me say something with regards to this. What we did in our department is we started a weekly journal club where we look at the most recent papers, actually just recently of Giovanni also, where we get to know the leaders in the field, where we get to know the literature, where we get to know the burning questions, and then try to implement them together as a team. How to treat a pancreatic fistula, what is new in this topic, and start discussion. And that really creates an interesting atmosphere where residents get involved in clinical decision-making, where they know some other studies where discussion starts. And that's something that I find personally very enriching. And that's a good, easy way to implement evidence-based medicine in your daily routine together with your team.
I love this answer, Daniel. Thank you. Thank you for bringing this human factor. I mean, again, it's absolutely key, right? I mean, this is really the human factor, integrated with AI. I see, questions in the chat box. What is the difference between a retrospective cohort study and a case control by Hemel Modi? Thank you, Hemel, for this question. So I have a question for you instead of answering you. Would you ask this to ChatGPT? do you think this question is suitable for ChatGPT? For example, because maybe you can find it on Google as well, right? I mean, what is the real difference? And if you don't find an answer there, and if ChatGPT provides you so, this is already something that will tell you that probably to go through this simple but not so simple question of yours, you probably need to study before getting a quick answer like this. So my feeling, and again, to be provocative with my two friends, Daniel and Povilas, we're friends since decades, is that we saw, because we are old enough, the shift between the world where every answer was difficult to be reached to the era where all the answers are possibly extremely easy to reach. You have Google on your phone, you have now ChatGPT, you have WhatsApp, or sorry to say, I don't want to make any adversarial commercial, but anyway, messaging, which is for free. Can you imagine that back in the day to talk to Daniel or Povilas, for me, it was a matter of money. Like I couldn't even phone to them. And now I can send a message and get an instant reply. This probably shrink a little bit our brain because there is no struggle, right, in get easy answer. So once again, AI is not here to provide you easy answer, but is here as a co-pilot to facilitate process that are in other ways difficult to reach. But always remember, you will never be anyone, you would get anywhere if you think that this will replace in some way us, as Daniel was beautifully pointing it out. I mean, what is beautiful about the Journal Club is to discuss, and I would never think that an AI could replace this factor, which is the key of the learning and the joy of this process that leads us to be here at 8 p.m. in the night instead of going home for dinner. By the way, we'll soon go.
There is actually an interesting question for Giovanni in the chat. You probably learn how to write manuscripts, analyze data, conduct literature research before the explosion of AI. What's your advice for people who are learning these skills now? Should we use AI as a helpful tool, or should we first learn to do things manually, more traditional way?
Thank
for
you
you,
for the
Giovanni. What
question.
do you
I think it's the same as asking whether you want to read a book on paper or on your tablet, right? I mean, this is not, again, a matter of replacing. I mean, there are definitely great tools to exercise. For example, we're all surgeons. Think about, how a robot now, thanks to AI, is able to provide training on your own, right? Just by plugging in, the simulator, and then you can really exercise. Whilst probably back in the day, you would have, I don't know, do it by on your own on a chicken by buying it at the grocery store. But what's the role of the mentor in this? I mean, the mentor will never be an AI-generated mentor because of the human factor. You need to have someone taking you by the hand and leading you where your dream could come true. So this we will never learn it from an AI-based platform, but AI-based platform would be a great tool for manuscript writing, testing it, and for example, correcting your English. None of us is a native English speaker. It's great to, provide a better structured English sentence by using an AI-generated tool. So once again, it's a co-pilot. It's not something that would replace the role of your mentor in becoming a good scientific writer.
And again, another question related to that, which I tried also to answer. Should we integrate AI courses in basic medical or residency training? So at least in Lithuania at our university, because I'm also involved in these things, we are already involving that, and we are talking a lot about that, and not forbidding for students or residents to use it, but actually what Giovanni said, we teach them or make them aware, both students, residents, and doctors and the teachers of the AI, that we can use it in the daily practice. And one last question. Thank you for a nice presentation. Can we use up-to-date Medscape or other databases as reliable as meta-analysis? Or can we use AI as scientific sources? So Daniel, do you use Medscape or up-to-date in your daily practice?
Yes, I use it since I think it's quite useful to use it. But you always have to be aware that there's an author who might have his own or her own opinion on things. So it's, I think, up-to-date Medscape are reliable, but there are no substitutes for meta-analysis. So you should always look at meta-analysis as well. But on a daily practice, it's easy if you just type something in, the same for ChatGPT or other sources. Make sure you are always aware that you should critically appraise it, even though it usually will find a good solution for you in your daily practice. So, of course, I use it since it's easier, but when I take it, I have to take into account that it might be at some form an opinion of a single person or an AI tool. That's how I would judge it.
Yeah, thank you. I think these were all our questions, and I would say we are already a little bit over 1 hour, and I would like to thank all the participants taking part at this first EBM webinar. We'll see in the future how it will be received. Do we prolong the webinar series or not? And I also would thank very much for Daniel and Giovanni to being here today with me. I think we'll be having many more courses on evidence medicine in the future. And then thank you, everyone.